The Committee on Finance, Insurance, and Consumer Protection is called to order. Will the clerk please call the roll?
Chairwoman Kavanaugh?
Here.
Senator Moss?
Here.
Senator McCann? Senator Bayer?
Here.
Senator Irwin?
Here.
Senator Heisinger?
Here.
Senator Tice?
Here.
Senator Daly?
Here.
Madam Chair, you have 8 members present. There's a quorum.
Thank you. I will entertain a motion to approve the meeting minutes from September 13th. So moved by Senator Moss. Hearing no objection, the minutes are adopted. We have no absent members. Before we begin today, I did want to touch on a couple things. I wanted to let everyone know that we are on a tight schedule, and as you can see, it is a full committee, and we have a lot of speakers. So we do have a hard stop at 12:30. Because of that, I may have limit spoken testimony for individuals to ensure that we can hear for everyone to have their space to talk about these bills. If we've unfortunately run out of time and you don't get the chance to speak, please know that your position and letters will be included in the record and shared with the members. Please limit, and I will reiterate when we invite speakers up, is less than 5 minutes each. And so first we're going to report out a couple bills that we heard last week. Today we will start by reporting HB 4377 and 4378, which were discussed with the staff members of Representative Carter and Representative Neely last week. Is there any additional cards that the clerk? Nope. I will entertain a motion to report HB 4377 to the floor with recommendation that the bill pass. So moved by Senator Moss. Will the clerk please call the question?
On reporting 4377, Chairwoman Kavanaugh?
Yes.
Senator Moss?
Yes.
Senator McCann?
Yes.
Senator Bayer?
Yes.
Senator Irwin?
Yes.
Senator Heisinger?
No.
Senator Tice?
No.
Senator Daly?
No.
Madam Chair, there are 5 yeas and 3 nays. The bill is reported.
Thank you. I will entertain a motion to report HB 4378 on the floor with recommendation that the bill pass. So moved by Senator McCann. Will the clerk please call the question?
On reporting 4378, Chairwoman Kavanaugh?
Yes.
Senator Moss?
Yes.
Senator McCann?
Yes.
Senator Bayer?
Yes.
Senator Irwin?
Yes.
Senator Heisinger?
No.
Senator Tice?
No.
Senator Daly?
No.
Madam Chair, there are 5 yeas and 3 nays. The bill is reported.
Thank you. Lastly, on moving the bills that we heard last week, next we will take up Senate Bill 331. That's Senator Hertel's bill, which we took testimony on last week. Any additional cards? I will entertain a motion to report SB 331 to the floor with recommendation that the bill pass. So moved by Senator Moss. Will the clerk please call the question?
On reporting 331, Chairwoman Kavanaugh?
Yes.
Senator Moss?
Yes.
Senator McCann?
Yes.
Senator Bayer?
Yes.
Senator Irwin?
Yes.
Senator Heisinger?
Yes.
Senator Tice?
Yes.
Senator Daly?
Yes.
Madam Chair, there are 8 yeas and 0 nays. The bill is reported.
Thank you. And finally, we will take up Senate Bills 483, 484, and 485, introduced by Senators Camilleri, Klinefelt, and McDonald, respectively. I'd like to welcome our sponsors if they're going to come up all together to explain their legislation. Welcome.
Thank you, Chair Kavanaugh and esteemed colleagues here on the Finance, Insurance, and Consumer Protection Committee. I come before you today joined by my colleagues and fellow bill sponsors, Senator McDonald Rivet and Senator Klinefelt, to share how our bills, Senate Bills 483, 484, and 485, will relieve Michiganders of the financial burden of rising prescription drug costs. As I talk to my constituents across Downriver and Western Wayne County and to Michiganders across our state, one thing is clear. The cost of prescription drugs is unreasonable. I'm thinking today of one woman in Groseal who reached out to me and told me that one treatment of her disease last month was suddenly $2,000 more than the previous one with no difference in the medicine. She told me it was taking up all of their family's extra funds. I'm also thinking of a man in Brownstown who told me that he's been filling his prescriptions in Canada because it's $250 per month without insurance over there versus nearly $1,300 a month here. Or the young mother who told me that she's been rationing asthma inhalers due to high costs. Stories like this are endless and it just goes to show how really needed this change is. This is a crisis that's only been getting worse for years. And at the same time, big pharmaceutical companies continue to reap record profits with little accountability. Nearly 3 in 10 Americans have skipped prescribed medicine because of the cost, while the biggest pharmaceutical company more than tripled its profits over the last 2 years. This cannot continue. It wreaks havoc on people's health and on their wallets. It forces people to make difficult decisions to feed their families and pay their utility bills or buy their medication. And it is time for Michigan to take a stand against Big Pharma's corporate greed and implement the Prescription Drug Cost and Affordability Act, which is what we have sponsored today, which helps establish the Prescription Drug Affordability Board, also known as PDAB. A PDAB is an independent body of experts who use data, analysis, and input from experts across the healthcare industry to identify drugs that pose an affordability challenge for Michiganders. The board's ability to set an upper payment limit, or UPL, is the mechanism by which consumers will see relief from rising prescription drug costs. The board is modeled after the MPSC, and once an upper payment limit is set by the board for a particular drug, it applies to all Michigan-based entities that purchase drugs meant for use in Michigan. That includes hospitals, pharmacies, plans, wholesalers, and the public. A UPL does not create new operational complexities for pharmaceutical manufacturers, nor the full supply chain, because all the operational components needed to implement a UPL are already entrenched in the industry business model. This board will be a forceful advocate for and take power back for Michigan consumers to help make life-saving prescriptions more affordable for Michigan residents and make pharmaceutical companies more accountable to the people of Michigan. Thank you for holding this hearing on this important issue. This is helpful legislation that I know our residents are going to appreciate and see the benefits of. I am now going to pass it along to my colleague, Senator McDonald Rivet.
Thank you very much. I feel very privileged to be able to be here and bring forward this legislation. So thank you, Chair Kavanaugh and members of the committee. Along with the legislation introduced by Senator Camilleri and Senator Klinefelt, I have introduced a companion bill to the PDAB, or the Prescription Drug Cost and Affordability Review Act, that would establish the Prescription Drug Affordability Review Board, or PDAB, in Michigan. In 2020, when we were in the middle of a global pandemic, costs of everything began to rise. At the same time, 500 prescription drugs skyrocketed by 2 times the rate of inflation. The greed across the system at the expense of our health and our livelihoods must stop. We have to act. As other states create similar legislation to address this problem, we must do the same in Michigan and hold Big Pharma accountable. Our bill package would create a 5-member board comprised of nonpartisan leaders in healthcare, economics, health policy, and clinical medicine. The legislation puts strict rules in place to ensure a very transparent process. We all know that the strength of a public board is its intention of centering and bringing the voice of our residents as the most important influence in the policy that we make. This board does just that. Board members must be individuals without financial ties to the industry, and we are requiring informed consultation in this process, and the board will be advised by the Prescription Drug Affordability Stakeholder Council. This 21-member council will include representatives with knowledge of the pharmaceutical industry, supply chains, clinical training, and more. These representatives could include pharmacists, healthcare providers, research drug manufacturers, even though, and especially, those whom the legislation will directly impact. There's ample room for input from people with skin in the game, with the independent, unbiased PDAB making the ultimate decision, all subject to the rulemaking process. A PDAB will help lower the cost of the most expensive prescription drugs for every Michigan resident, employer, small business, pharmacy, and health plan, and bring much-needed accountability, oversight, and transparency to pharmaceutical companies, making them more responsive to customers. The overarching goal of the PDAB is to find a UPL at which insurers, employers, purchasers, and governments can afford to provide the drug to everyone in the state who needs to have access to the drug. Because the point of an upper price limit, despite everything that you are going to hear today, is to expand sales and patient access. Our constituents are our everyday focus, and right now, many of their everyday drug costs are unnecessarily extreme. We all have the personal stories, and to be perfectly honest, it was my intent to share a personal story with you today. But I don't need to, because we all know them. We are personally or our family is affected by copays that exceed thousands of dollars a month. This independent Prescription Drug Affordability Board will bring those extreme costs down, improve health, and save lives. Thank you for your consideration.
Good morning. Thank you, Chair Kavanaugh and members of the committee. I am proud to join Senator Camilleri and Senator McDonald Rivet in sponsoring legislation that will create a PDAB in Michigan to safeguard Michiganders from the ever-increasing cost of prescription drugs. My bill simply says that any insurance provider in the state that covers prescription drugs has to abide by the UPL that's been set by the board and the rulemaking process. The Prescription Drug Cost and Affordability Act openly and democratically evaluates what employers and the public are being asked to pay for their medicine, and as a result, the whole industry can benefit. A PDAB that lowers cost of a product through the supply chain ultimately lowers the cost of the product to the patient at the pharmacy counter or other place of service, which is exactly what our residents want. We have an opportunity here to end price gouging, to bring down the cost of prescription drugs for people of all ages. I am encouraged by the support we've already seen from this package from doctors, patients, insurance companies, employers, labor, pharmacists, and the governor. I am hoping for bipartisan support here. I look forward to working with all of you on this. Thank you.
Chair Kavanaugh, members of the, thank you for your time, and we will be available here for answering any questions. But we also, I just want to point out, have a lot of experts with us today to talk through the mechanics of how this will work. I know it's a big idea. Big ideas are complicated and they can take time to understand, but that does not mean that they should stand in the way of progress. When we're implementing a program that is going to lower the cost of Michiganders, we want to ensure that experts are helping us craft this, which is why we brought so many people today to explain it some more. So we'll have them here as well for those technical questions, but happy to answer any questions right now as well.
Thank you, and I appreciate you guys' testimony. I do have a quick question. Why this avenue as legislators? Why a board, and why do you think this might help solve the problem?
So I think when we look at the transparency that this will bring to the process, we are shedding a light on an industry that has been gouging patients for years, and we're seeing this happen in states all over the country with the Prescription Drug Affordability Board. And so as states are starting to lead, we are hoping that we will be able to be in that strong position to not only unlock the transparency, set those upper payment limits so that we can actually get real results in the pockets of our residents, but be, as a state, a laboratory of democracy as how we are trying to rein in the costs of those prescription drugs. This is one of those avenues that other states are taking. We just want to be part of that fight and part of that initial wave of people who are taking on an industry that we know has been making record profits at the expense of patients.
Three politicians with access to a microphone. I want to add to that. I think that Senator Camilleri is right, but I want to say as a newbie legislator, 9 months into my first term, the thing that's really noticeable is how often we lose sight of the people that we're legislating for, how often they are not a part of in the center of the policies that we are passing. And this board that brings transparency to the process is that notion, as I said, of centering people in this work and bringing them into the process. But most importantly, and it may not be perfect, but doing nothing cannot be an option.
And just very quickly, there's going to be a council that advises the board, and that allows every stakeholder with any position to give input into the process, and I think that's important.
Thank you, Senators. We do have a couple questions. Senator Huizenga.
Thank you, Madam Chair. I think this question is probably for Senator Camilleri. When we look at the way products go through the supply chain, and you mentioned that there wasn't going to be an impact on operations. My expertise is in this area of pharmaceuticals and working closely with biologic drugs and infusion centers and hospitals around the country for 20 years. One of the challenges is that the operational side of it says that when a product is sold, reimbursed, Medicare makes a determination on a quarterly basis and says, what's the average sale price of this product throughout the country? And they adjust it quarterly, and they add 6%. So it's called ASP plus 6, modified, again, every quarter. Even the state of Michigan uses that model for reimbursement for Medicaid. If we had this control board that says the upper price limit would decrease below that or even at that level, clearly, it's just math. Both Medicare and Medicaid people could be at risk. And although we're trying to help our residents, I think it's a misguided process that says that we would change that model because these are federal statutes, or this is the way it is across the whole country. And the consequence, I think, would be then that our hospitals, physicians' offices, infusion centers that provide these life-saving products that keep people out of the hospital, and they may even be anti-neoplastic agents, people with cancer, for them to not have this because someone just say, look, I can't sell a product that's very expensive at a negative margin. No one would do that. How do we get around something like that? Because operationally, and again, conceptually, we all want to lower costs, but operationally, this would not do that.
So I'm going to let you have a chance for a little bit of a comment, but I do want to uplift that there will be a little bit of subject matter experts to go a little bit more in depth with that answer, but go ahead.
Yep. So when we're setting an upper payment limit, we are setting that highest amount for reimbursement. That is the number that will be reimbursed, whether it's through the consumer paying directly out of pocket or the insurance company paying that cost. What that then does for the rest of the supply chain, that does not eliminate people making their margins along the way, because we know that that is part of the process, unfortunately. What it is really getting at is the high exorbitant cost that the pharmaceutical companies are charging at the beginning of the process, which then gets filtered all the way through to the top. If we're setting an upper payment limit that we know is the most amount that an individual can pay, we are still building in the opportunity for profit. I want to be very clear here. People are still going to make money throughout the entire system. What this will also do, in my opinion, is that instead of those unbelievably expensive drugs having one at one pharmacy that gets sold once per month, we know that there will be more patients who know they can have access to those drugs because they're at a cost that is much more affordable. And so I actually believe this will ensure more medicine is getting out to people who need it because it's at a payment that people can actually conceptualize and realize that they can attain. I don't want to see people rationing their medicine because they can't afford it. What this, I think, will do is actually ensure more medicine is out in the market for the patients who need it most.
Thank you. We're going to go Senator Tice.
Thank you, Madam Chair. I think we can all agree that figuring out how to reduce the cost of prescriptions is urgently necessary. Please understand, I'm not disagreeing with that. But I have a few questions. The way that this is written, it creates an autonomous board that then writes its own rules, that then speaks with the force of law, that would then need to be appealed to, from what I can tell, directly. If you were a pharmacy and you thought that they made the wrong decision, you'd appeal back to them. And if they were to find against you, they charge you for having appealed their decision under the rules that they made. Am I getting this wrong?
I don't know that it's exactly in the way that you've described it, but I want to say that for any board that we create in the state, just like the MPSC and other governmental bodies that are created by the legislature, we are empowering the board to have a certain set of functions. Part of those functions are setting that upper payment limit. Individual pharmacies are not the target here. I want to be very clear. We are targeting big pharma and the manufacturers. And so I don't believe that pharmacies themselves will be appealing to the board around an upper payment limit.
I said pharmaceuticals.
You said pharmacies, that's what I heard at least. But if you're talking about the big pharma manufacturers, they are the ones that would, yes, have to appeal to the board. And to be honest, as a public body, I would love for them to explain why their medicine is so expensive and why they need to see us as consumers paying more out of our pocket for whatever costs that we, as the public, do not fully understand. And so I do think there's a component here that when they are appealing to a public body, they're explaining to us as consumers how much medicine may cost, because I think from our perspective, there is far too much going into the pockets of those who are CEOs and the top earners of this company, and not really trickling down to the consumers themselves. So boards get the amount of power that we give them. We are giving them significant amount of consumer protection power because that's what our residents have demanded.
Thank you, and we do have to move on, so I appreciate, oh, if you want to do one last comment.
Just very quickly, keep in mind one of the things this board is going to be tasked with is evaluating. So they're going to be looking at prescription drugs that have skyrocketed over time that were once affordable. They're going to be looking at every drug individually and what the history of it is too. And I think the target is the drugs that people rely on a regular basis and cannot afford anymore. And as for the pharmaceutical companies, I don't think it would be their position that they're going to stop doing business in Michigan. I think that they would continue. That's my opinion.
Working at a negative?
Thank you. We'll have a little bit more time with some of the experts that we'll have. Thank you, senators. So please excuse me if I pronounce your name wrong. Please come up and correct or introduce yourself. First, we will be inviting or hearing from Jane Horvath, who I do believe is virtual.
Yes.
Hi, good almost afternoon. Can you hear us?
I can hear you. Can you hear or see me?
Yep, perfect. Go right ahead.
Okay. Oh, okay. Start right. So thank you, Senator Kavanaugh, Chair Kavanaugh, and members of the committee for this opportunity to talk about Prescription Drug Affordability Board and the overall sort of pharmaceutical market that we have in the U.S. today. Just briefly by way of background, I've been doing this kind of work for a long time now. I worked originally for the Medicaid directors on designing and then implementing the Medicaid rebate program. I worked with former Michigan Senator Regal's office on designing the Vaccine for Children's program. I worked at Merck helping to implement with the industry the Medicare Part D program. And when I was at the National Academy for State Health Policy, I designed this prescription drug affordability model and wholesale state importation, drug importation. So I've been thinking about this a lot and how to make sure that all the different parts of the U.S. pharmaceutical market are not harmed. But the ultimate goal is to get it product to the patient at a price that is affordable. So I just want to focus on three broad areas, and then I hope we can have a robust question and answer time. So just the price of medicines has been rising dramatically in recent years. In 2017, the average launch price of a product was $2,100. And by 2021, it was $180,000. And last year, the median launch price was $257,000. So this is creating a real burden in the healthcare system writ large. And that also pharmacy benefits comprise about 23% of our healthcare premium dollars now, and that's net of manufacturer rebates. The second area I really wanted to touch on is the dysfunction in the total marketplace now that is created by these very high prices and the fact that almost all drugs are coming out at extremely high prices. So like manufacturers, PBMs, employers, health plans, everybody has developed different strategies to deal with these costs. And I would say that the only market participant without a business model to try to address these costs and sometimes profit off of these very high prices is the consumer. And all of this has been incredibly detrimental because they really are in the middle of this struggle to manage these costs, and they have no say. And I really wanted to just focus on the solution, which I think is embedded in the concept of a Prescription Drug Affordability Board. But in thinking about any of this and in addressing all the dysfunction that we see that leads to all the finger pointing among the industries that we see about whose fault this is. It's everybody's fault at this point. So the solution to just sort of ratchet all down and have the market operating in a more sane, functional manner, you need transparency. You need transparency of price, costs, and the discounts. And that transparency has to travel through the supply chain to the point of service to the consumer. And then it has to be this upper payment limit. The upper payment limit is the transparency. Basically, it is a very public number. Everybody knows what it is. It has to be statewide. It has to be all payer, all purchaser. It's sort of consolidating the Michigan market for a variety of reasons. One is ease of implementation. One is just market leverage. There's many reasons, but it really does need to be statewide to operate optimally and protect all consumers, including the uninsured in the state of Michigan. So no one can buy or bill more than the upper payment limit, but people can certainly pay. And I just also wanted to say that the notion of healthcare rate setting is ubiquitous in our healthcare system. Nobody pays what they're charged. They pay at a rate that they have decided they're going to pay. So this is nothing unusual. And I'd also point out that the U.S. Supreme Court, in a decision at the end of 2020, reaffirmed clearly that state healthcare rate setting is totally within the unquestioned authority of the state to. So I think we need to keep that in mind. And lastly, I just want to say that this is not the whole upper payment limit and the construction of the board. None of it is meant to be punitive against any market participant. It's an affirmative thing. It's meant to expand access by patients to the products that they need. And actually, when you get right down to it, it's meant to expand market access for the manufacturers. And manufacturers are always very concerned about market access. And this should open up market access for drugs with a UPL. And I'd love to take your question.
Thank you for your testimony. I do want to mention that there was a couple questions from members for the sponsors, and I'm not sure if you wanted to touch on those really quick, if you were able to hear those.
Yes, but I'd need them slightly reprised.
Oh, that's okay. I'll just hand it
mind.
over. Yep, Senator Huizenga.
Thank you, Jane, for your testimony today, and I appreciate your expertise. I'll ask the same question. Currently, pricing is set by the average sale price of these products across the country, plus 6% for Medicare and for Medicaid, those that I would consider some of the most vulnerable that are impacted by these decisions. If we set a lower price, will it not inherently create a situation where the provider, whether it's the hospital, infusion center, or physician's office, will see a negative margin on the product?
Well, this is designed so that absolutely doesn't happen. That's not the point of this. The point is not to leave any provider holding the bag. So the product is going to come in through wholesalers at the upper payment limits, basically. And so these infusion centers are going to be purchasing the product at the upper payment limit and presumably slightly below so that they can make a margin. Medicare, we're going to have to work this out with Medicare, but my understanding is that, Medicare reimburses what it understands a provider purchased the product for. And so you wouldn't necessarily have average sales price here in Michigan. You would have the upper payment limit plus.
But if the feds and the state both use average sale price plus 6% and you decrease the upper payment limit, the margin is essentially 6%. So if you take that away, then or reduce any sort of upper payment or create any upper payment limit that's lower than that, then they would be at a negative margin, right?
No, they wouldn't, because they would be purchasing the product that they infuse or whatever. They would be purchasing it at the upper payment limit. The upper payment limit is the cost. It's what you buy and you bill for in the state, and it starts with the wholesaler. So this is, we're not regulating the national price of a manufacturer for the product. We're regulating what in-state licensed entities and bill for this product.
These are products that
So
all
it
have
starts with the
national,
wholesale.
yeah, but these are products that all have national drug code that's basically sold at the same price across the state. Are you saying that we would see a lower price in the state of Michigan only compared to the rest of the country?
Yes.
So then so then there'd be excess margin then for Medicare, because Medicare pays ASP plus 6, and so you'd be creating an artificially lucrative environment, which would do the counter to what you're thinking.
I don't believe so, sir. I think Medicare, they have regional claims payment centers that, you know, you can adjust your claims payment amount fairly easy. It's like just an IT issue. I would expect that Medicare would do UPL plus 6.
Has
Medicare's never
any other
averse to
state done
saving
that?
money.
Because nationally, it's
Sorry?
the same everywhere. Has any other state done that? Because nationally, every state for Medicare, all regions, all local offices pay ASP plus 6. It's national policy.
That's correct. They do, but there is also another Medicare policy that says, other than this ASP, because nobody knows exactly what any infusion center is paying. That's why we have average national sales price plus 6. So some really large entities who can negotiate and get it for less than the average national average sale price, you know, they make a nice margin with that plus 6. That plus 6 is also really meant to help smaller centers who don't have the market clout to get the drug, possibly higher than the national average sales price. So there's 6% margin protects them. Medicare may still choose to pay plus 6%. They may still choose to reimburse ASP plus 6, but I doubt that. Again, Medicare is charged with not overpaying.
Thank you. We do have a couple other questions. Senator Moss.
Thank you, Madam Chair. We're talking about the consequences of setting an upper price limit and what the consequence of a lower price might be. But in your experience and your expertise in this, what are some of the determining factors that have led to price increases? I think some of the more egregious examples have been greed. I think about Martin Shkreli and the HIV medication that went from $18 to $800 just because he wanted that margin, a profit. So experience, what have been some of those determining factors that have led to some of these increases?
So an increase can happen because the plant in which the drug is manufactured needs to be updated to come into code with FDA, and that would cause an increase. I know when I was at Merck, we made a very old product, mustard gin, I think it was, and it's still in use. It is a very old product, and the plant that made it was very old, and we either had to stop making it, and I believe it was a cancer product, or upgrade the facility. And so ultimately the price of that product went up a great deal, caused a lot of problems. But again, that was a factory thing. Other than that, there may be a situation where supply has really ratcheted up and you have to increase your manufacturing capacity in some way, which would cost money. So that might be reflected in a price increase. But more generally speaking, it really is a matter of they make projections to Wall Street about what their sales and revenue are going to be, mostly revenue. And if they're not hitting those targets, they will raise their prices to meet Wall Street expectations. And you can watch, if you watch like HIV products, the first mover is going to announce their price increase in January, and then everybody else with a similar product in that therapeutic class, their price increases tend to be very.
And I would just mention too, or at least maybe you can expand upon it, you know, as other states are looking at price protections, other countries have looked at price protections. They still have found a space for R&D. They still found a space on the market, and the United States has, if you took the most expensive drugs here and the most expensive drugs in Europe, there's a huge gap in disparity there.
There is a huge gap, and there's I believe it was a study done by researchers and published in JAMA, and I might have my facts slightly off, but the general trend, I think, is clear. They were saying that the price differential between some number of products, the price differential between US and average European countries, just that differential was enough to fund R&D, global R&D for those. So yeah, there's room to move.
So I guess in summation, do you feel that the establishment of this board and protection for consumers, do you think that is going to threaten accessibility of prescription drugs here in Michigan?
I don't. I thought if consumers were going to get hurt, this would not be a worthwhile effort at all. I think manufacturers operate in all the countries that control prices, direct price controls. They operate there, they make profits there, they build manufacturing plants there. It is fine, basically. And what manufacturers really do not want is someone taking authority over their kind of unlimited ability to price. And that makes them very nervous. But no, I don't. A sale is a sale. Basically, a manufacturer is not going to decide to not play in Michigan. Number one, Michigan is a very large state, big market. So if a manufacturer chose not to sell their product at the UPL, they'd be walking away from the market, number one. They would have a lot of reputational damage, number two, because a UPL that a board comes up with is not going to be crazy.
And more people would have accessibility to it at that point.
Thank you.
More
Thanks.
sales.
Yep, we have one more question, and I'm just going to ask if you could be precise, and we need to move on to a couple other speakers. One question, please.
Absolutely. Senator Moss, I just want to say I totally agree with you. Greed is something that we need to address. I'm 100% on board with that. With this bill, are you aware of any place in it that requires this board to review cost of R&D and cost to manufacture in order to set the price limits? And can you tell me where?
I believe it is one of the provisions in there, but there's also, manufacturers are pretty loath to provide that information. And so the board doesn't have authority to demand it from them. You know, what the manufacturer chooses to provide is completely voluntary. So, I mean, that's it. If it is important to the price of the drug that the manufacturer has set, I would hope that a manufacturer would make that case, basically, and provide that information. But the board has absolutely no authority to command data from the manufacturer.
So they'll be making these decisions without knowing the cost?
If that is what the manufacturer chooses to happen, then yes, that is the way that will happen.
Thank you. And I do want to note that Jane will be on Zoom for the duration of the hearing if questions are best answered by a subject matter expert or herself. So thank you for your testimony and the question and answer. I appreciate it. Next, I want to invite Dr. Rob Davidson and he is the Executive Director, Committee to Protect Healthcare. Welcome to committee. And apologies if I cut you off, but we are on a little bit of a tight timeline.
No worries. I'm an ER doc. I speak pretty quickly and a parent of three. Thank you, Chairwoman Kavanaugh and members of the committee for the opportunity to speak today. My name is Rob Davidson. I'm an emergency physician who has served in my rural community in West Michigan for more than 20 years. I'm also the Executive Director of the Committee to Protect Healthcare, a mobilization of physicians in Michigan and across the nation advocating for pro-patient healthcare policies. Our organization is proud to join 17, I think now maybe 18 organizations as the signatory of the coalition letter in front of you, calling for action on prescription drug costs by establishing a Prescription Drug Affordability Board. I'm speaking in support of the bills considered today, which will establish a PDAB because I see firsthand how patients suffer from adverse health outcomes because they cannot afford to get the medications that are prescribed for them. In some cases, they're patients I may have just prescribed medications a few weeks earlier, but wound up back in my ER because they simply couldn't pay for the drugs. I'm urging you to support a PDAB for patients across Michigan so we can finally keep runaway skyrocketing prescription drug costs in check. My patients sometimes put their health at risk because they have to choose between buying groceries to feed their children and paying for medications. A couple examples. A few months ago, in the last 6 months at least, I saw a patient who came to the ER with chest pain. They were seen a few weeks earlier for a blood clot in their leg in our emergency department. They were prescribed a blood thinner that could have kept this at bay, easily treated, but they didn't take it because they said it cost almost $1,000 and they couldn't do it. They came back in and had a blood clot in their lungs, ended up having to get admitted to the ICU. So simple treatable condition developed into a life-threatening blood clot in the lungs because of cost. On another occasion, I remember about 3 o'clock in the morning, because I work a lot of night shifts, a guy being wheeled in a wheelchair, clutching an inhaler, gasping for breath. He had to be put on non-invasive ventilation. And he said he couldn't afford a new inhaler. That's why he was there. A simple cost of an inhaler caused this person to have to come to the hospital rather than being able to be managed at home. When you can't afford these drugs, you run the risk of getting severely ill like these people did. People actually die every single day from diseases that could have been treated if not for the cost. And it keeps getting worse. Every year I see patients' medications go up in price. My patients deserve to know why the medications they need to be healthy keep getting more expensive. They also deserve to have a legislature that has their backs when it comes to keeping costs in check, not one that puts big pharma's profits ahead of people's health and safety. I'm asking you to stand up for my patients and their families. These are people you may know personally who couldn't afford the medication they need to stay healthy or alive. They may even have families from the rare organizations who are terrified by big pharma's threats to take away the drugs upon which they depend. These folks are hostages to that industry and the status quo that they prop up to keep raking in those massive profits. The fact is that 1,300 new drugs come to market every year. This PDAB will impact the most expensive of these drugs after rigorous review and stakeholder input. These changes will take place on a reasonable schedule that allows Big Pharma time to adapt. At the end of the day, as physicians, we want our patients and families to be able to get the medications they need at a cost they can afford. You have no idea how frustrating it is to train for over a decade, to serve for 2 decades in a community, and then to see people like I described and others simply not able to follow the instructions you give them and the medications you prescribe that you know will save their life just because they can't afford it. A PDAB can help bring more transparency, make medications more affordable, and help more Michiganders get access to health care that can improve and save lives. I urge you to pass a PDAB and help your constituents and my patients get the medications they need. Thank you.
Thank you for your testimony. I do just want to reiterate, I appreciate your experience. I know we all have a personal story of a friend, a family member, and how high drug costs just to stay healthy or treat. So I appreciate your testimony. I want to open it up for any questions. Senator Huizenga.
Thank you, Dr. Davidson. I appreciate your testimony today. One of my concerns is products that are also human-derived that are considered pharmaceuticals. So think of things like PIG. How do we have a board that's going to be quick enough to say, look, these products are commodities, they're human-derived, and the ability for us to make sure that we're not going to see hospitals like yours underwater with products like that where they're just inherently volatile?
I think I can let the subject matter experts speak to the specific products, the biologics, the human-derived products, other pharmaceuticals. I can just speak to the fact that if these are drugs or biologics or human-derived products that are required for patients to not die in a very blunt terms, it should be something they can afford. You know, I am not a subject matter expert. I am an expert in emergency medicine, and I just feel that emotional cost my patients, you know, they tell me about every day. But that's why I'm here.
Thank you. Thank you for your testimony. Next, I'd like to invite Sharice Johnson, Director of State Policy at Pharma. Welcome to committee.
It's a long walk up here. Is this on? Okay, thank you. Good morning, Chairwoman Kavanaugh and members of the committee. As you stated, my name is Sharice Johnson. I'm Director of State Policy at Pharma. Thank you for including the industry in today's discussion regarding Prescription Drug Affordability Board, or PDAB legislation. Patients need to be able to both afford and access their medications. No one should have to choose between paying for bills or fulfilling a prescription. I know how heavy a burden that can be. At 16, my grandmother moved in with our family so that we could help care for her progressive Alzheimer's dementia. Due to high copay costs, I worked extra tutoring and babysitting jobs to help afford the medications that aided in slowing my grandmother's illness. Unfortunately, we believe prescription drug affordability boards will not have the intended effect of lowering patients' costs, and in fact could hurt their access to critical medications. PDABs not only create boards that consist of unelected members that can arbitrarily policies that won't necessarily have a positive impact on patients' cost, but some, like SB 483, also empower these members to set an upper payment limit or a cannot obtain a therapy at the state prescribed price, or UPL, and or if a pharmacy or dispensing provider cannot stock the drug because it too cannot meet the state prescribed price, then the medicine will not be available to patients. Additionally, providers could be left with substantial costs if they acquired the drug before the price control is in place, yet could not bill for reimbursement that covers their acquisition costs. PDAB legislation threatens to drastically reduce the development of new medicines at a time of remarkable scientific promise, undermining U.S. global leadership in biopharmaceutical innovation. Innovation that gave my family and I more precious time with my grandmother, time where she was still herself. Government price setting diminishes the incentive for biopharmaceutical manufacturers to invest in research and development of new medicines. History shows that when foreign governments have set the price of medicines, research and development, investment and innovation have greatly declined because governments choose which diseases are worth investing in and which are not. The fact is the system of innovation we have today works extremely well. New treatments and cures are reaching patients, improving lives, and generating savings across the healthcare system. Analysis confirms that total spending on medicines is a small share of U.S. healthcare spending and is expected to remain just 14% of total health spending over the next decade. PDAB legislation, like the one being discussed today, focuses on the list price or sticker price of drugs and ignores the reality of deeply negotiated discounted prices the plans are actually paying. This type of legislation fails to account for middlemen and other actors in the supply chain who actually have control of the ultimate prices that patients pay at the pharmacy. Out-of-pocket costs paid by consumers for prescription drugs continue to rise despite rebates, discounts, fees, and other price concessions doubling in the last decade to $180 billion in 2020 and totaling more than $256 billion in 2022. Much of that is not making its way to offsetting patient costs at the pharmacy counter, with some patients paying the list price of drugs while their health plans or pharmacy benefit managers, or PBMs, retain manufacturer rebates for those same drugs. Insurers increasingly shift costs to patients through deductibles and coinsurance. Situated between the biopharmaceutical companies that research and develop innovative medicines and the patients likely to benefit from those treatments, PBMs play a central role in controlling prescription medicine access and affordability for hundreds of millions of Americans. Through horizontal and vertical integration, PBM's role in the prescription drug supply chain has grown, as has their influence over which medicines patients have access to and whether they are affordable for patients. In fact, negotiating powers are becoming increasingly concentrated among fewer and fewer PBMs, with the three largest PBMs holding nearly 80% of the market share. This market concentration has sparked attention and inquiries from government entities like the Federal Trade Commission, or FTC. In 2022, FTC announced that it was launching an investigation into the PBM industry to scrutinize the impact of vertically integrated pharmacy benefit managers on the affordability and access of prescription drugs, with congressional hearings occurring today in 2023. In addition to the shrinking competition within the PBM market, insurers increasingly shift prescription costs to patients through cost sharing and coinsurance. Despite manufacturers' rebates and discounts negotiated by health plans or their PBMs, nearly half of commercially insured patients' out-of-pocket spending for brand medicines is based on the medicine's undiscounted list price. It is imperative for real change in affordability and access for patients that the entirety of the supply chain be considered. PDAB legislation like SB 483 here in Michigan neglects investigation into the impact insurers and PBMs have on the out-of-pocket costs incurred by patients at the pharmacy counter, which we believe is at the root of affordability. It is important to note that nationally drug price growth is slowing or flattening. When you back out rebates and price concessions, net prescription spending has risen at or below inflation for 5 years running. In 2020, net prices for brand medicines declined by 2.9%.
I apologize. I do want to leave a little bit of time for questions. I know we got over that 5-minute marker. So I did have just an initial question on your testimony. it was stated that it consists of unelected members that can arbitrarily set policy. I just want to, I guess, ask, and I'm not sure if you would be the appropriate person, but unelected members, if they were elected, would they be more qualified rather than, I think in the legislation, we make sure that it's people that have experience as far as health policy, health economics, and clinical medicine. So I'm just wondering.
And they also exclude members of the biopharmaceutical industry as well.
Okay. Yep, so I just wanted to ask that because from what I read from the policy, it has a little bit of experience to the board who will be making some of these decisions along with the 25, but I just wanted to ask. I appreciate it. I want to open up for the committee of questions. Senator Moss?
And I'm listening to your testimony, and I'm hearing this argument that it could stifle innovation. R&D is a means to an end, and the end is people benefiting from the R&D, and they should be able to access those benefits. So what good is a medicine that people who need it can't afford it? I think that's the conflict here. What are the solutions from your end that pharma can provide to reduce these costs?
Towards the end of my testimony, I was going to get into suggested policy solutions that we also pulled Michiganders as well, which is like rebate pass-through from insurers and PBMs to the consumers themselves, as well as acknowledging copay coupons towards deductibles as well. And then, it takes about 10 years and $2.6 billion to bring one drug to market. So the investment in research and development is a high risk with hopefully a high reward at the end for patients. So I hope I answered your question.
The prevailing notion, too, is that there is a benefit, a revenue benefit to pharmaceuticals. What would you say are the revenue benefits to pharmaceuticals on keeping prices artificially inflated? I mean, what are the revenues for the largest pharmaceutical companies from the U.S. market?
I don't work for those particular individuals. I work for the trade association, so I can't speak on behalf of any of their revenues. But what I can say is that if you're looking for transparency, this bill does lack any investigation into the other players within the supply chain, like PBMs and insurers who are in charge of benefit design and where drugs are accessible, where they fall in the coverage and tiering as well. So,
Thank you. Senator Huizenga.
Thank you, Madam Chair. One of the benefits that I think that we know is that in the last 15 years, we've seen really incredible changes with especially biologic drugs, those that are oftentimes seen as probably the most expensive because of the high complex nature of production, essentially genetically changing and modifying to match up with the disease as the condition states. But when you talk about things like breast cancer, or that used to be a kiss of death, or we see things like lung cancer, where incredibly bad diagnoses that have seen actual incredible turnarounds. And not only that, but we see additional life-saving solutions for other disease states from these same products through the research that's conducted. Can you talk a little bit about how those costs and how we try to put a cost like that with saving a life? And especially recognizing that Medicare and Medicaid cover these products, and these are products that save others, and that when it comes time for augmenting with coupons, medication assistance programs, and things like that, that the augmentation that the industry typically provides is for the commercial payers, because you can't legally do that for both federal and state programs like Medicare and Medicaid.
right. So something that was discussed by members of the committee here was the different prices of treatments and medications in other countries. What wasn't talked about was the access to treatments like cancer treatments, and the most cutting edge or innovative treatments are not available to those patients for sometimes several years, upwards of 10 years. So the access for patients in the U.S. is incredible, and that things like this, these pressures downward on it, will have a chilling effect on that innovation and that access, yes.
Thank you, and we do have to move on, so I appreciate your testimony. I do apologize if I have to cut you off. We are running about 3 minutes per testimony. So if I can call up the next 3 from Michigan Association of Health Plans, Dominic Poloni, Carrie Germain, and Christine Shear. Just Dominic and Carrie.
Thank you, Madam Chair and members of the committee. I appreciate the time here today, and we'll be as quick as we can in delivering our testimony. My name is Dominic Polone. I'm the Executive Director of the Michigan Association of Health Plans, and our association represents 11 health plans licensed and regulated here in the state of Michigan, serving over 3.2 million Michiganders here today across all markets, Medicaid, Medicare, commercial, et cetera. We also have 55 business and limited members as a part of our association, and here today with me to help give more expert testimony than I am able is Carrie Germain, a pharmacist and now a MAHP pharmacy consultant for us. And we appreciate the opportunity today to allow us to testify in support of Senate Bill 483 through 485. The prescription drug affordability boards represent one of the most potentially impactful areas of legislation at the state-led effort to control drug pricing. In general, prescription drug affordability boards is constituted by a panel of experts charged with identifying medicines that are of high cost burden to the state and its patients. This legislation also sets, as you've heard from others, upper payment limits for particularly expensive medications, and the boards may also investigate abrupt medication price increases and act to counterbalance them. I'll turn it over now to Mr. Main to give you some more details about the legislation in front of you today.
Thank you, Dominic. Can everyone hear me? Thank you. We all know someone who's benefited from innovative and life-saving medications, and it has been mentioned. Treatment advances have allowed patients to live longer, healthier lives with their families. Unfortunately, we may also be familiar with individuals who cut back on their medication or stop taking it altogether. I have seen that many times in my career because it was unaffordable. This can lead to progression of their condition and result in poor health outcomes. Rising prescription drug costs are a complex issue that we need to address head-on, and it's critical to work together to find those solutions that address this important issue affecting healthcare affordability for Michigan citizens. Drug prices are consistently rising faster than any other consumer goods, resulting in drugs that have become unaffordable for consumers and increased healthcare premiums for everyone. According to a report from the U.S. Department of Health and Human Services, between July 2021 and July 2022, list prices on more than 1,200 prescription drugs rose faster than the 8.5% inflation rate, rising at an average 31.6%. One strategy to evaluate and control those prescription drug cost increases that's being enacted in 8 states and proposed by Senate Bills 383 through 385 is creation of this PDAB. The PDAB, as has been mentioned, is a state-appointed panel of individuals with expertise in healthcare economics, healthcare policy, clinical medicine. Individuals who are prohibited from serving on the PDAB include anyone who's employed by, acting as a consultant to, or serving as a board member of a drug manufacturer or their trade association, and someone whose personal or financial interest has the potential to bias the individual's decision in those matters that are brought before the PDAB. The board is supported, as mentioned, by the diverse council that represents manufacturers, purchasers, clinicians, healthcare providers, insurers, and a variety of consumer groups. Like the state's Public Service Commission, who reviews those public services and utilities, the PDAB monitors the prescription drug prices. It's just as simple as that. The PDAB impartially evaluates impact of the drug cost on the healthcare system, considers input from the stakeholders, including manufacturers, and identifies drugs for an affordability review. For drugs with significant annual costs and increases that can pose affordability challenges, the PDAB may recommend implementation of an upper payment limit, or UPL.
Thank you.
Thank you.
do apologize. I do want to open it up for a little questions.
Thank you.
And I will start with the first one. We have heard a little bit of concerns about either pharmacists or recouping. Can you explain what a maximum allowable cost is, and from some of the concerns that we've been hearing?
Sure. Part of my life for almost 40 years, maximum allowable cost is the price that's set by a health plan who is paying the bill to the biller, who is the pharmacy, for generic medications. So if you think of that as the generic side of the UPL, which is going to be likely a brand medication. And so the health plan or the PBM who services the health plan and has contracted with the pharmacy can set up an upper limit price that they'll pay on a generic medication where there are multiple sources for that medication. When the pharmacy sends a claim to the health care, the plan or the PBM, then they get paid up to that amount of medication. If they send a price lower than that or an amount lower, they will be paid that amount. If they send something over that maximum allowable cost or MAC price, they will be paid that MAC price. They will not be paid in excess of it. So I equate that to something similar to what is being established in the upper payment limit for a brand medication.
Thank you. I appreciate it. Any further questions? Senator Irwin.
Thank you, Chair. We've heard a little bit, and we actually got some written testimony about orphan drugs and the Orphan Drug Act. I'm wondering if you could address that concern, if you can, and talk a little bit about the Federal Orphan Drug Act and whether that provides any protections against some of the concerns that we're hearing people raise.
So for those that are not familiar, an orphan drug is one that is used to treat 200,000 or less people in the country for a similar condition. Those medications are usually funded or be funded by government agencies, and they contribute to the research, the trials that go into developing those medications. So they're not commonly used medications. They are, I will say, generally very expensive medications. And as you stated, the folks that need them want to have access to them.
Thank you. Senator Huizenga.
Thank you, Madam Chair. Can you describe, not for the retail side of things, but for if we looked at an oncology center, for instance, are your health plans reimbursing at MAC, WAC, or ASP plus 6?
I am not familiar with that answer. I'll defer to Dominic.
I would have to go back and check because I don't want to tell you the wrong answer here in committee, Senator. So let me take that back, and Madam Chair, if it's all right, I will share through you so that others can have the answer as well.
That'd be great.
Yeah.
Any further questions? I appreciate your testimony.
Thank you.
Thank you.
Next, I'd like to bring up Sarah Stark, a patient, and she is on Zoom.
Hi, thank you, Senators Camilleri, McDonald, Rivet, and Klinefelt, and thank you to Chair Kavanaugh and the committee for hearing my story today. My name is Sarah Stark. I was diagnosed with type 1 diabetes at the age of 7, and I have been a consumer of insulin for more than 25 years. For many years, I sat in shame and guilt caused by the overbearing financial burden this disease has imposed on myself and every single person that I love. Over time, I translated that shame into a justified rage. Watching the cost of a single vial of insulin skyrocket from $25 to more than $300 in just the span of my diagnosis alone is more than enough to do that. For the past quarter of a century, the price of insulin has been at the forefront of every major life decision I've ever had to make. My living situation, my educational path, my career, whether I could get married, and if and when I could have kids, have all been determined by the price of my insulin. That is shameful. That shame is not mine to carry. An average of 1 in 4 insulin patients have had to ration their life-saving medication. I have fallen into that statistics at various points in my life for reasons as trivial as a paperwork error. In the past, I've spent a significant amount of time helping to organize mutual aid with a network of diabetics across the country. We crowdsource for insulin and related financial needs, and in doing so, we keep each other alive. This is not our job. We don't have a choice. For all of us, the option is pay up or die. People like me rely on life-saving prescription drugs such as insulin to help live healthy, fulfilling lives. Yet we have little to no say in how much we are forced to pay because big drug companies hold all the cards and call the shots. If big pharmaceutical companies oppose a PDAB, I know it's the right choice for Michigan. I urge you to vote for this legislation to create a PDAB so we can rein in these skyrocketing costs so that everyone can afford their medication. We all know the big companies have an army of lobbyists working for them. Some of them are here today. It's time we have someone looking out for us. So I want to thank Senator Camilleri, Senator McDonald Rivet, and Senator Klinefelt who are sponsoring this legislation. If other states can do it, we can do it in Michigan. And I wanted to touch on something that's come up a lot today in this hearing, and it's the cost of R&D. I want to pose the question why patients are expected to bankroll research and development. Why are sick people expected to pay for that? Second, there's public data provided by companies each year. Eli Lilly, for example, 25 years of company data shows that in that time period from 1996 to 2018, the cost of insulin had increased by over 1,200%. R&D, that data was available. That remained stagnant, but stock buybacks, that went up significantly. So when you're asking about R&D, I think that it's really important to look up the data and the facts because they are out there. Thank you, and I'm so happy to take any questions any of you may have.
Thank you so much for being available for your testimony. And I really appreciate your testimony, the openness, the honestness. And I think it's exactly why we're here today, not only to discuss the legislation, but hear how it's affecting all Michiganders, our families, and who we know. So I just want to open up for any questions. Senator Tice.
It's just more of a statement. I firmly believe you have a right to be very, very angry. Obviously, R&D is not applying to your medication, so I don't know that any of us are arguing with that point. So I do also thank you for bringing your story forward. I think it's really important.
Thank you. And with no further questions, I appreciate your testimony. We're going to move on. Next, I want to invite Stephen Rapundalo. Please correct me. Welcome, and President and CEO of Mish Bio. Yep, little button on the, yep.
No.
Yep, there you go.
Okay, great. Sorry about that. Yes, good afternoon. My name is Dr. Stephen Rapundalo. I'm President and CEO of Mish Bio, the statewide life science trade association. And we represent the full spectrum of research-based life sciences industry. So that's everything from the large biopharma to the small early stage startups. It's the academic and clinical research institutions, as well as patient advocacy organizations. You know, I think it's important to recognize, and I think some alluded to it earlier, you know, Michigan was at the forefront, one of the leaders in getting us out of the pandemic. And that was our industry that was developing, manufacturing those vaccines and treatments and diagnostics, all to keep all of us safe and healthy. And it's that same entrepreneurial spirit that underlies drug research and development around many other therapeutic and disease areas. And I should know, I spent 20 years in pharmaceutical research, developing drugs that are on the market, some of you that you might be taking, or your family or friends. But I want you to know that this is a huge innovation cluster in the state. We're top 15 in the country, over 44,000 jobs, 2,400 facilities, all working to try to bring cures and treatments to patients. But the fact of the matter is that these bills are nothing more than price controls. And I think somebody talked about innovation and how that will continue. And the fact is, over the course of my pharmaceutical career, it took me all over the world to R&D centers. And wherever those countries instituted price controls, take a look. Those R&D centers are all gone. Jobs eliminated time and time and time again. I don't care if you're talking about Germany, Switzerland, UK, Canada, what have you. Moreover, the patients in those regions and others with price controls have less access to new medicines. There are numerous studies that have demonstrated that. In one particular study from ICVIA, between 2011 and 19, 87% of new medicines were immediately available to American patients, while only 63% with a 10-month delay in Germany, 50% with an 18-month delay in France, 51% with a 16-month delay in Japan. I grew up in the Canadian health system. I can assure you it is not everything it's cracked up to be. The delays are there with the price controls. My one daughter lives in the UK and cannot get access to the same drugs that she had access to here in the United States. And I can go on and on. Look, we all want to, I'm a patient, you're patients, we're all patients. We all want to be sure that our out-of-pocket costs are the most affordable that they can be. But these bills are not going to change one dime out of my pocket or your pockets when this is all said and done. And so let's work together. Let's take the time and the due diligence to work out a set of policies that will have ensure that they cover all the supply chain and not just one aspect over any other. So needless to say, we oppose these bills. Thank you.
Any questions? I do have a quick question. I know you mentioned that this will absolutely not lower prices. Is there any data or evidence on that statement?
Well, we've already, I know we're already feeling and seeing the signs of the federal implications of the Inflation Reduction Act. So that's a set of price controls at the federal level. And those are starting to cause companies to make serious decisions about their R&D portfolios. And what that does is has a trickle-down effect to the early stage companies, ones that were just presenting down the street the other day. Some of your colleagues were present. Because the big companies are not going to be able to then afford to buy the new drugs that are coming on the market. There just simply won't be a market.
Okay. And lastly, I do want to just uplift a little bit before handing it over to further questions. Something that we heard from the testimony prior, as far as, and within your testimony of entrepreneur leadership and being the innovative on the, not necessarily, but on the backs of the consumer. And we're talking about blood thinners, diabetics, on things that people need to survive. I don't think it's an either or scenario. So I just wanted to make that statement. And I'm going to hand it over to Senator Irwin for his question.
Thank you, Madam Chair. Thank you, Mr. Rapundolo, for your testimony. If the legislature does move forward and create some sort of prescription drug advisory board, with some sort of language behind it, I think we all know that it's going to be governed by the Administrative Procedures Act, and there's going to be a lot of process around selecting the individuals, interviewing the various manufacturers and other folks in the supply chain to try to determine what are the best drugs to focus any effort on, or which are the drugs which may be real outliers in terms of costs. Would your association, MichBio, participate in that process to try to assist this board in making the right decisions?
We would be happy to help in any which way we can. If we could bring that kind of expertise to the table, absolutely.
Thank you, Mr. Rapundolo. I only asked the question assuming what the answer would be because I know that there's a lot of uncertainty when we talk about creating a board that would have certain authorities, but I want to highlight the fact that there are laws that govern their procedures, laws that require public hearings and certain transparencies that will allow entities like pharmaceutical manufacturers to come in and say, here is our case as to why our drug costs what it does. Here is our case about research and development going on across the world, which I, assume will direct a lot of the conversation towards some of the abuses that patients and healthcare providers have seen in the market.
Fair enough, but I think at the end of the day, it is an elected board. It is one that is obviously at the mercy of, the administration's, the governor's appointments, and that obviously can change as with cycles. So to me, that's not a body that can be the most effective, as well as one knowing that those are people that are going to have operational knowledge of the drug development processes and associated, costs and expenses.
Thank you. Senator Bayer.
Thank you, Madam Chair. And just a little bit more on that same line of questioning. The hearings, this would be a public hearings, public discussion about the costs. And so the ability to talk about the actual cost of doing the R&D, of the actual, for specific called out items, right? Specific drugs, not everything. It seems like a willingness to provide that kind of information for this new board would make a big difference when you talk about the actual costs and what the actual impact would be in changing things. And we look at actual profitability in some of the big companies that are members, right? I mean, you know, $23 billion in profit last year is a lot of money. No matter how you look at it, there's cost to R&D. $7 billion, right? It's important. It's a big amount of money. It matters to us. But by not being able to actually look at it, if you would be willing to participate, it would make a difference in the decisions on what can we do to make this better. When we compare to what's happening overseas, when you look at the prices down there and the discussion that you started with was people there don't have access for some period of time. Eventually it gets to them. One of the things that we're not great at here that is probably more consistent in other countries because they have price controls is equity in distribution of medicines. So here, if you are very wealthy, you can afford these hugely outrageous prices for new drugs, and the rest of the people cannot. They simply can't get them. And so that's a big difference in a social policy that may also have an impact on that. So what do you think about that? Do you have a...
Well, I think that you're absolutely right. I think we as a society have not grappled with that and had that discussion and come to an understanding of what we're willing to pay for or not. I think other societies certainly have done more of that, but you suffer the consequences of those decisions.
But then they can serve all their people, even if they don't get the drug till a year later.
I would argue as a former patient candidate that was not, in fact, true. I can argue that my daughter is not getting that kind of access that she had here in the UK today. So, but that's all anecdotal.
Thank you.
Thank you.
Close on time. Senator Tice.
Thank you, Madam Chair. Just reading from the bill, the governor shall not appoint an individual to the board if the individual is employed by, a consultant to, or a board member of a manufacturer or trade association for a manufacturer, or otherwise has a personal or financial interest that has a potential to bias or has the appearance of biasing the individual's decision in matters related to what the board does effectively. And then also, this completely removes the legislature from being a part of the process. We have utterly delegated, doesn't even go to JCAR, utterly delegated our authority in this. So remove the ability for the individuals to actually have a strong voice in the process, and we remove the legislature from having any voice in the process. I think your concerns are valid, that we are prohibiting them from being a part of this. Thank you.
Thank you. Quickly, Senator Moss.
I keep hearing unelected board, unelected board. Right now, unelected people are making these decisions in the dark. And the legislative leaders of both chambers have the ability to make appointments to this board. And because it's legislation, we have the ability to tweak, amend, and strengthen the legislation in the future. So I just wanted to make that clear. Right now, unelected people are making these decisions right now. My question, too, for you is, I mean, do you think that there's any sort of price gouging in the industry? Do you think that there's any sort of bad actors making these decisions? And don't you think that any sort of transparency before a government approved board is a good thing to root out the bad actors, regardless of R&D, regardless of supply chain, price gouging? Shouldn't we have more tools to go after that?
There's no question that there are bad actors. You've read about them just as I have, and we don't condone those any more than anybody else. But, you know, I think somebody mentioned earlier about the cost of R&D. Might have been you, Senator Bayer. You know, the $7 billion that you quoted is only one company. I know because I worked for one that spent at least that. I mean, so there's tens and tens, if not hundreds of billions of dollars spent. And they're not only trying to pay for the one drug that made it, they're also trying to pay for all the 40, 50 that didn't make it during that cycle. It is, look, it's a commodity, right? You pay for other goods and services This just happens to be very expensive, but they're life-saving, and there's a value and a price tag for the life-saving and the cures that they bring too that has to be factored in.
And I hear your comments on one end that, you know, the medication, the drugs will not be available to those who need them. Well, right now, the price limitations make it unavailable to those who need them. So we're at a conundrum here.
I would argue that's a benefits design problem, not a pharmaceutical manufacturer.
I'm more than willing to enact a board to field these justifications in an open and transparent process, because ultimately one of the titles of this committee is consumer protection, and that's what we're tasked to do. If there's a role for us to play here, we should be part of the solution.
Thank you, and we do have to move on. I appreciate your testimony. So we are running on 10 minutes. Might go 15 without my members being a little too upset. But I do want to apologize to anyone that we might not be able to go to in person or in virtual. But next, I want to invite Justin Mendoza, Executive Director of Universities Allied for Essential Medicines. Welcome.
Hello, thank you so much for the time today. Thank you, Senator Kavanaugh, and the rest of this wonderful committee. My name is Justin Mendoza, Executive Director for Universities Allied for Essential Medicines, and for the past 20 years, we're an organization of students, researchers, medical doctors, and attorneys who believe that our system of biomedical R&D is broken, and it leaves people to try to pick up the scraps in the healthcare system and without the access to the medicines that they need. The Michigan Prescription Drug Task Force already found that nearly 1/3 of residents aged 16 to 24 stopped taking their prescription drugs because of cost. And that's a really key thing that I think we have to focus on here. While consumers are suffering, drug makers lobby so they can enjoy unchecked drug costs and windfall profits. If we look at just last year, the industry spent more than $370 million lobbying Congress over one bill. It's no surprise to see industry voices testify today that the same talking points that we've been hearing for years when Michigan, one of the largest states in the nation, considers using its power to review drug costs and set upper payment limits. I'd like to start by dispelling a couple of myths. First, the myth around innovation. The U.S. taxpayer, through the U.S. government, takes on the most of the risk of drug discovery, not drug corporations. In 2022 alone, the National Institutes of Health spent a budgeted $42 billion on basic science research. That's the risky research. And if indeed the industry is betting on the future of their medicines, they began by betting with money from the House. Even when industry does take a big swing in investment, like when Gilead Pharmaceuticals purchased an entire company for $11.6 billion in 2014, one of the biggest acquisitions in the history of the industry, they were able to leverage just one drug from that portfolio to bring in $12.1 billion in revenue in just 12 months. Ask a Subway owner if that's good revenue. In 2015, U.S. Senators Ron Wyden and Chuck Grassley led an investigation into the introductory price of that medicine, and they actually uncovered a color-coded chart articulating a number of factors that were used to decide the list price of that drug. They included the opinions of lawmakers like yourselves, patient advocates' statements, views of the insurance companies, views of physicians, and other stakeholders. It did not include research and development costs. Any reasonable interpretation of that data gives the impression that setting the drug's price is an inherently political act. Regardless of how these prices are set, we've heard testimony today that drug prices continue to climb year after year. At the beginning of 2023, more than 350 drugs already on the market saw a price increase beyond inflation. And where exactly are those dollars being spent? We already heard about stock buybacks. I do want to also mention the R&D costs mentioned before. We heard about the average of $2.6 billion, but a peer-reviewed study published in the NIH's publicly available data from 2021 actually shows that it varies widely, ranging from $161 million to develop a new drug before approval for something more simple, up to between $944 million and $4.5 billion for more complex cancer drugs. So when you take away the anecdotes and you take away the broadest average, you're actually able to look at peer-reviewed data that says that that number is not accurate. Beyond that, in terms of delays across markets across the world, That is true. There are delays. In Europe, cancer drugs are delayed by about 403 days on the market. But researchers looked into the reasoning behind that, did not point to or to price caps or cost controls. What they pointed to is differences in the regulatory process. Notably, the US government uses an accelerated approval process for those drugs that is not mimicked in European regulations. So if you want to look at why we're not getting on the market, that's the reason. I'll end this just really quickly by saying the PDAB creates common sense rules of the road so that patients can be protected, rather than just the interests of drug company shareholders and their CEOs. This is a smart policy that's already been tested in 7 states: Maryland, Colorado, Washington, Maine, New Hampshire, Ohio, and Oregon. And 3 of those states are utilizing an upper payment limit already. It's time for Michigan to use the power of our market share to pressure these companies to play ball. It's time to pass this bill.
Thank you so much for your testimony. We do have a few questions. Senator Moss.
Thank you, Madam Chair. We've heard about these drugs for rare conditions, which are more expensive because of the innovation and R&D. In your experience, because we've heard this talked about these drugs, should they or should they not be subjected to PDAB in the scope of this legislation?
Absolutely. All drugs that pose a significant cost in the state of Michigan should be considered. The main reason behind it is the Orphan Drug Act was intended to find those drugs that truly needed folks to recruit, right? 200,000 patients means you're doing a clinical trial with just a couple hundred. It takes a long time to recruit those folks, and it is expensive. However, the system has been gamed time and time again. Humira, the best-selling drug in the entire world, received 5 extra years of exclusivity from the Orphan Drug Act by gaming that system and finding more indications that fit the definition of an orphan drug. Until the federal government reins that in, the state should consider the cost of those drugs as well.
Thanks.
Thank you. Any further questions? Thank you for your testimony.
Of course.
Next, I'd like to invite Pete Rigney, patient, National MS Society, and I believe he will be virtual.
Thank you so much, everyone. I know it is getting towards lunchtime, so I'll make this brief as I can. My name is Pete Rigney. I live in Lakeview with my wife, Jen, 2 stepchildren, and what feels like a domestic farm of animals. I'm here because I'm among the nearly 40% of people living with multiple sclerosis who have altered the use of their medication due to cost. Before I was diagnosed 12 years ago, numbness and tingling started in my right hand. Then, while training new runners to complete their first 5K, I, a lifelong runner, could not keep up with them. Escalating the situation and changing doctors quickly led me to my MS diagnosis. I was initially prescribed beta-seron, a self-injected disease-modifying therapy, or DMT, that has been shown to modify the course of MS and prevent the accumulation of disability. Symptoms and prescription therapies vary widely due to how unpredictable the disease can be. I tolerated beta-seron for 1 year and transitioned to Gilenya, a daily pill, which I was on for 6 years. I then started Ocrevus, a twice-yearly infusion, which I was only on for 1 year. I'd also like to make an added note that in the written testimony submitted by Corbin McGee from the National MS Society, you'll see a graph that shows how expensive these medications are, with beta-seron having an annual manufactured price of $119,000 and Gilenya having an annual manufactured price of $126,000 in 2023. With each transition came new price ranges. Fortunately, I have employer-sponsored health insurance. Between health insurance and copay assistance, I paid little or nothing for these treatments. However, because I know jobs come and go with the swing of the economy, I felt forced to always hedge my bet. First, I didn't take my Gilenya as prescribed by skipping days so I could accumulate a 6-month surplus in the event something happened to my job. Next, I was given a choice between two top-tier medications due to the progress of my MS. And I chose the medication not recommended by my neurologist. And the only factor I considered was if the medication I chose, named Mavenclad, worked as intended, I might not have to be on any disease-modifying therapies again. This would mean I wouldn't have to constantly worry as much about having an unexpected lapse in employment. Now, let me be clear, skipping doses of medication and making decisions out of step for my neurologist due to cost and not health outcomes should never be the norm. However, as I said before, in a recent study done by the National MS Society, over 40% of people living with MS have altered their treatments, just like me. And every new lesion on my brain or spine due to any changes or lapse in treatment is irreversible. I strongly feel that no one should have to make these kinds of decisions. Medication cannot improve lives if people cannot afford to access them. The National MS Society and Michiganders living with MS support Senate Bill 483 through 485 and their intent to bring more transparency, discussion, and attention to the high cost of prescription drugs for people with chronic conditions. We appreciate the Prescription Drug Cost and Affordability Review Act would utilize a multi-stakeholder approach in acknowledging the roles of health plans, employers, clinical researchers, drug manufacturers, patients, and others. And we urge this committee to ensure the wording in the legislation is clear, that the members on the public who sit on the stakeholders council be Michiganders who have been impacted by high drug costs. People with a chronic illness like MS need to know they'll be able to get the life-changing medication they need and when they need it. I urge you to support the Prescription Drug Cost and Affordability Review Act, and thank you for your time.
Thank you, Pete. I appreciate it, and I appreciate your testimony. We are running at 12:33, and I am going to squeeze one more testimony in before calling it a day. So I appreciate everyone being here. And lastly, I want to call up Melissa Seifert with AARP.
I'll be so fast. Well, thank you, Chairwoman Kavanaugh and members of the committee. On behalf of our 1.2 million members statewide, AARP Michigan is supporting Senate Bill 483 through 485, which would establish a Drug Affordability Review Board. Low cost of prescription drugs is a high priority for AARP. According to a survey conducted by AARP in 2012, 3 in 4 Michiganders, which is 75%, report taking prescription medications on a regular basis. And 58% cite not filling a prescription because of cost. Older adults are disproportionately affected by high prescription drug costs, with 40% taking 5 or more prescription drugs and nearly 20% taking 10 or more. More than 57% of Michigan adults 50 and over are concerned they will not be able to afford prescription drugs over the next few years for themselves or their families. Consumers have faced unfair drug prices for years, and the situation has only gotten worse. A recent report by the U.S. Department of Health and Human Services noted that list prices on more than 1,200 prescription drugs rose faster than inflation, rising an average of 31.6%. The price of Januvia, a popular drug used to treat diabetes, has increased more than 275% since entering the market in 2006. AARP's RX Price Watch report found that in 2020, prices for over 180 widely used specialty drugs increased more than 3.5 times faster than general inflation. The current high cost of prescription drugs is outrageous and unsustainable, which is why Michigan voters are demanding action. According to a survey conducted by AARP in November of 2022, 74% of Michigan voters age 50 plus support Michigan establishing a Prescription Drug Affordability Board. Until this bill, the board would be able to review drug prices, as we all have been talking about, We urge you to support Senate Bills 483 through 485 to help ensure that Michiganders can access and afford the medications they need, because the best drugs in the world don't work if you can't afford to take them. So thank you.
Thank you, I appreciate it. We do not have any questions,
Great.
and I appreciate the members who are able to hang back a little bit, and everyone here. It is a big topic and a big priority that we are talking about, and I do think that we need to talk about it, and we need a solution. And so I appreciate the bill sponsors and everyone here from both sides that were able to give some testimony today. And I do want to reiterate that if you are not able to speak, please know that your position and letters will be included in the record and shared with members. The cards will be considered read in, and the clerk will include all position in the minutes. And with no further business, without objection, the Committee on Finance, Insurance, and Consumer Protection is now adjourned.